Well, hello and welcome to another podcast from Odell Technology. Today, we're fortunate enough to be joined by Dr. Mark Slack, the Chief Medical Officer of CMR Surgical and one of the founding members, the 5 founding members of CMR Surgical. Hello, Dr. Slack.
Hi, Stephen. Nice to see you again.
Good to see you again too, sir, and welcome to the podcast. Dr. Slack, if I could just ask you to describe your professional background from your days as a young graduate doctor to the world you're in now, please.
Right, no, that'd be a pleasure. So, as you can probably hear from my voice, I grew up in Southern Africa. I am trained as a doctor, junior doctor there, and then did my specialist training. I did the first part in Johannesburg, then in Cape Town, and then decided to come for a bit of additional experience in the United Kingdom. Came across, found I liked the health system. I found the equity on the NHS something quite special. I liked the fact that people didn't have to pay for it, and entered into the NHS, where I've remained as a full-time consultant for the rest of my career, most of it at the beautiful city of Cambridge. During my career, I've always had an incredibly big interest in research. So I've underpinned my entire career with research, academic research, and I've also done a bit of inventing of products as well. So I entered into an agreement with 2 major medtech companies and took 2 of my inventions to global launch. So it's been a sort of a mixed career, academia and a bit of inventing as well.
Okay, so what was your medical specialization?
So I specialized as a gynecologist, or in fact, initially as an obstetrician gynecologist. So I used to, at one point in my life, deliver babies. But I then believe in subspecialization. So I dropped obstetrics and I subspecialized as what you call a urogynecologist. So I was a gynecologist who specialized only in pelvic floor disorders. Okay.
And I think everyone's asking, how did the CMR story start? Because I think it was you commenced as 5 people in 2014. Is that correct?
Correct. So my co-founders were all Cambridge people, working in medtech development in Cambridge. People make an assumption that Luke and I, the technical guy, met through my background and his background. Me having done a lot of developmental medical engineering work with engineers, mostly from large pharma companies. But indeed, Luke we met through the NCT, because my wife was attending classes there and on her own. And the person in charge sort of said, "Did she have a partner?" And she said, "No, she's married." And she said, "Well, you should bring your husband along." And she said, "No, you'd rather he stayed at home." Anyway, Luke approached my wife, who's a surgeon, and said he wanted to talk to her about robotics. And she said, "No, you're talking to the wrong men of the family. My husband is going on about robotics all the time, and he's got an idea that he would like to make some improvements." And so Luke and I got together, and it was like a meeting of minds. He had such brilliant ideas. They fitted with where my mind was. Then Paul, Keith, and Martin got into it, and we formed a wonderful working relationship between the 5 of us.
Okay, so the question then is, why robotics?
Yeah, absolutely. Just to add to that, and all my previous, you make mistakes when you're going through inventing, and so all the previous experience, my academic research, have all put me almost in an ideal position to develop a complex instrument like this. So why robotics? Why I was going on about it, which is why my wife knew it, was that I've trained laparoscopic surgeons for 25 years. And it's a long training course. It's 2 years per surgeon. And I realized that's keyhole surgery. And keyhole surgery's got massive advantages. It reduces complications by 50%. It reduces, if an open wound gets infected, half of those patients go back into hospital and 20% go back to theatre. That alone costs the European economy about 27 billion euros a year. If you do minimal access or keyhole, you get the same infection rate, but none go back to hospital and none go back to theatre. So we could save billions of euros. And so, but despite all these advantages, and I found that I couldn't really train people to the level I wanted them at. And so I started looking at the literature, and of course that then came out. In America, one of the most sophisticated health systems in the world, only 40% of surgery that could be done by keyhole is done by keyhole, with still 60% of people getting open surgery. So that's what struck me. So clearly after 35 years, keyhole surgery is just too difficult for some people to actually really get good at. And therefore I wondered, would robotics, with its magnified vision, its 3D vision, the articulated instruments, provide a way of getting more doctors doing it and therefore more patients receiving it with all the advantages? So that is, but I didn't think the robot in the market was answering all the questions, and I wanted different things from the robots, which is why we embarked on, sometimes in retrospect, the rather maniacal route of building one's own robot.
Absolutely. But the responsibilities of I think you started in 2014, you were first to human in 2019, is that correct?
Correct.
And
Yes.
where was your first, where did that happen?
Yeah, so that is a frighteningly fast development. There are companies many billions of dollars bigger than us who have tried for 12, 13 years to build robots and failed. So it was a remarkable achievement by the team that we built around in Cambridge, very bright group of in many cases, very young engineers, and massively hardworking and dedicated. So I must never forget the team that actually achieved it. But it's such a big and difficult thing to do. And of course, there's the fear factor that you don't want to get it wrong. And in the past, there have been medical innovations that have not come to market safely. So what we've done is we've built an ecosystem around it. So while we were building the robot, we also developed a registry. So when we went live in humans, every single patient that we operated on went into the registry. We also used an academic collaborative process called the IDEAL to make sure that we went through. So I did 350 cadavers operations before we saw a live human. So we knew exactly where to put the ports and the positions and the bedside units and everything. And so it was a responsible introduction. We also simultaneously developed a very mature educational system, and we validated it against outcomes. And of course, and in fact, in the beginning, that was a massively expensive program. It cost us thousands of pounds to train each team. But we wanted to prove that it was safe. And then once we knew we were safely training and implementing, then we started changing our training and our profit program to make it more affordable, while at the same time maintaining standards.
Okay, so that's part of the responsibilities of the project. Tell me, I've been in numerous discussions about robotics over the past few years, and robotics, I think the people who are leading robotic surgery see it as a tool, as an instrument for a variety of different things. Could you carry on with that, please?
Yeah, absolutely. So all it is a tool. It's a very fancy tool, and it's a very complicated tool, but it's a tool to provide more precision, better visualization, and better control. And also, it's difficult to explain on a podcast, but in normal laparoscopy, if you move your hand right, your instrument goes left. And, it's two-dimensional and it's quite difficult. In robotic surgery, if you move your hand right, your instrument goes right. You've got 3D vision. And in fact, I can train, if I was going to take a complete novice and teach them how to tie a knot with normal keyhole surgery, that can take 60, 70 hours. On a robot, I can teach you in probably an hour. So, massive.
I think I saw a video once of you teaching them a Minister of Health to do it in 5 minutes.
Correct. Well, 30 minutes. Yeah.
30 minutes. That's pretty good.
We taught the Secretary of State of Health to tie a knot, and I have shown that to people coming to watch it. So I put them on a 2D conventional laparoscopic system and get them to just try and pick up a needle and pass it from one instrument to the other, and they can't do it. Then I put them on the robot and they can do it pretty easily. So that's where it came to. It wasn't just a robot. That's where it came to implementing it safely. So we then embarked on a huge clinical program. So every single thing we did, we published in peer-reviewed literature. We did large cohort studies in different parts. You asked the question earlier, where did we start? Our first in human was in India. The reason for that, enormous patient numbers and
Yes.
some of the most experienced surgeons in the world.
Absolutely.
So the first hospital was just an amazing hospital, absolute privilege to work with these gentlemen and ladies that work there. And but we also had the numbers, which meant we could get the data quite quickly. And then we, so the clinical program continues to run. Our most recent publication is publishing our registry results in Annals of Surgery, which is one of the best journals in the world, and showing that our registry not only does it work, here's the data. And
Yes.
so I'm able to compare my data with the established literature, knowing that we're doing it safely and we're doing it, ethically. And so that's the other parts of it, clinical research, professional education, data, all the bits that surround the program and make sure that it is safe and ethical.
And also, I think I know in the past you've discussed a responsible implementation policy.
Yes.
For people, and I think that's a rather important point.
So in the 90s, in the 90s, when keyhole surgery was being widely introduced, it was mayhem. People were doing tiny short courses and then going solo to operate, and many people were injured and damaged. And indeed, in Europe, there were moves towards trying to ban it.
Yes.
And then governments got sensible. They put quite a large money into training centers. They matured the training, and then they put it out. And as a result, we now have these amazing results with keyhole surgery. So we've done that very much with implementation. So we see implementation as a package. So we sell you a robot. We then take you to our training center and train you. But we train the whole team. We train the nurses, the anesthetist comes. And we train against what we call proficiency-based metrics. So it's not just time-based. You actually have to pass certain tasks.
Yes.
You then come back to the hospital. We practice with the surgeons in the hospital, and then we go to what we call implementation. So our engineer comes to the site, makes sure everything's working properly. Our professional education people have trained the people to the point, and then they hand over to an implementation team. And in the first few cases, we've got an engineer to make sure any things with the machine can be dealt with immediately, and the implementation people guide the team through that phase. But at the same time, we pay for experienced robotic surgeons to sit alongside the surgeon and monitor them and proctor them, as we call it.
Okay,
and
so there's a learning curve.
There's a learning curve, and only then does the surgeon go live. And if you talk about a learning curve, the wonderful thing about a robot is every bit of movement I gather on the system. And we also look at the outcomes data from the registry. So in the beginning, the learning curve was about 35 to 40 cases, and we now know it's around about 15.
Okay, so that's a lot faster than traditional training.
Correct. And we can also show the learning curve. So, and if a person's not achieving the learning curve, we know it. So they may need a bit of extra supervision or a bit of extra help.
Okay, that's fantastic. I know in your training, you've done something rather revolutionary with the special glasses. Can you tell me a little about that?
Yeah, so it's, training, as I said, was very expensive. So we had to find some way of reducing costs. And also hospitals are really pressurized because it's difficult for them to release staff for 4 or 5 days. They've got patients to see and deal with. And so we've introduced virtual reality headsets. So when you're learning, the robot is so complex, the arms have got buttons, alarms, everything else. And we've put this on the virtual, so you can sit at home, Stephen, and you can practice with the bedside unit and the arm, learn the alarms, how to move it, how to set it up. Then we have a simulator, so the surgeon can sit and practice how to tie a knot and everything. So when they come to us for their first training, they already have quite a large degree of proficiency. So that's meant we can shorten the training course, but lose absolutely no of none of the standards.
Yeah.
And then when we implement, so we've managed to, and then the latest thing is we've always trained people in cadavers, and there are ethical anxieties that some of the segments of the science worry about. So we've actually, over the last 18 months, developed mannequins to use.
Fantastic.
And these, one, improve training, and two, reduce costs hugely. So we've reduced the cost of training by about 80% without any impact on the quality of the training. And in fact, with deliberate learning, the mannequin almost makes it better.
Yes,
and there's no
indeed.
distraction by the cadaver. People concentrate on the robot. So to me, I love the robot. I
Yeah.
love robotic surgery. But the things that make me proud of what's happened here is this very mature training system that goes around it. The fact that we monitor all the data all the time, and we know that we're doing it safely and responsibly. So those are the sort of things that really, and then we're driving a range of digital products. So you can get your data on an app on your phone. And you can get your videos on an app on the phone. So
that serves a great purpose. I wanted to ask, it all leads to clinical outcomes, doesn't it? And how are you, is your robot improving clinical outcomes?
yes, I think so. I think I think in the first instance, does minimal access improve outcomes? Hugely. Well described, no argument about it, but not enough people get it. So by teaching more surgeons to do the robot, more get minimal access, and therefore more people get better outcomes. But we are starting to also see improved clinical outcomes because it is a robot. So it's got articulated wrists. It can get in tighter areas. So with my robot, we're showing some real advantages in transoral surgery, in chest surgery, and we have early work to show advantages in pediatric surgery. So where cavities are small and surgeons have struggled with keyhole surgery, it starts to show advantages. So there are early papers. And then the other one it shows is a robot doesn't necessarily make an elite surgeon better, but it does make a less elite surgeon much better. So it narrows that gap between top and bottom, which is just so good for patients.
That's better for all of us, really, isn't it?
Exactly.
Okay. Well, no, I really appreciate your time today. It's very good of you to offer your time like this. So, Dr. Slack, I think if we could discuss the prognostic value of a robot, would you elaborate on that, please?
Yes, I think we're starting to see now. In the beginning, the demand was from the elite innovators, early adopters. We're now getting demand from routine surgeons in relatively small hospitals who want to use it. And it's two reasons. One is they have bought into the fact that this will make them better keyhole surgeons and will get them better outcomes and therefore will treat their patients better. They personally are also wanting it because they have less damage to themselves. With straight stick laparoscopy, people get a lot of neck problems, a lot of arm problems, massively fatiguing, tiring. Female surgeons struggle with routine laparoscopic equipment because it's made for people with bigger hands. And so all those features are driving people towards more robotics. So I see uptake from big teaching hospitals and from small district general hospitals and from private hospitals. So the demand is big. And I asked the president of one of the Royal Colleges his prognosis for 10 years. And he said keyhole would have gone up from 40% to about 80% of surgeries, and 90% of those will be done by robots.
Oh, wow.
Yeah,
Okay,
or robotically assisted. So I
Yeah.
think we're going to see, and in commercially, it is considered to be the fastest growing med tech sector ever.
Absolutely.
And I'm comfortable with that because actually it's driving better outcomes. And I think what's happening, Stephen, is that with digitization and with data becoming more accessible, people are becoming aware that not all surgery has been accompanied by good outcomes. And people start to drive and demand it. I was at a do at one of the Royal College of Surgeons yesterday, and I spent half an hour with the patient representative groups who are coming to visit us. And they want to know about data. They want to know about outcomes. They want to know about fatigue. So I think we're going to see the world driving towards improved outcomes. I mean, annually there are over 1 million people who die as a complication of as a result of surgical complications. And I just think that's going to be a massive driver towards increased uptake. And the thing that is potentially inhibited, when I when we decided on the design of our robot, which is quite different from the others, we did it in consultation with the doctors. What did they want? And we've tried to match what they wanted. And one of the barriers has been cost.
Yeah.
And one of the problems has been people have just said, how much does a robot cost? That's more expensive than normal keyhole, therefore we can't buy it.
Yes.
And as you well know, it's a way more sophisticated argument. You've got to say, let's look at it over 6 months. So I might pay more for the robot, but if that increases my keyhole surgery and I reduce the complications and I get people back to work quicker, actually over 6 months, the cost is considerably less. And we're doing a lot of work on health economic outcome research and we want to do a lot more in the future. You know, it's an area now that we are getting mature with the robot and, you know, we have a stable system. We want to actually re-engage in that sort of research to actually prove, because I think one of the things that we have to engage in the world is value-based medicine. You know, America is struggling with its costs, and I think it's got to be evidence-based and it's got to be value-based, you know, for the community that we serve.
Absolutely. I think a lot of you see that happening in a lot of systems currently. Tell me the value of augmented intelligence to the robot and to the community in if I could incorporate the word augmented intelligence into a robot, how would I go about it?
Well, that's almost the most misused word in medicine, but it's also the most one of the more exciting ones. Because our robots, so the robot's an amazing thing because it actually captures data that would otherwise have been lost between the patient and the surgeon. And we have telemetry, so every single movement is mapped, and we have it all on a cloud. And we've been teaching the robots the difference between an experienced and an inexperienced surgeon. And it can, with a 99% accuracy, tell whether the surgeon is experienced or inexperienced. So that's just, and we've done the work. We have it ready for publication. We did a series where we took 8 experts and we took 8 novices, and it identified 7 out of 8 in each group. We then looked at the videos, and the one novice was remarkably good, and the one expert maybe not as good as they thought they were. So that was that's just a glimpse of, wow, you could monitor standards with that. And then, one of the big injuries you get is in ordinary laparoscopies, the surgeon's looking at his left-hand instrument and pressing the diathermy button, but the diathermy is attached to the right-hand instrument and burns the patient without them realizing. So we can put into the system, we haven't done it yet, but we know we can do it. When you want to do the diathermy, it will only let you do it if the instrument is in vision, i.e. you know that it's safe.
Yes, of course.
And then just so many other things. We've used artificial intelligence for videos. So your danger is you having an operation and somebody's videoing your operation. When they take the camera out, there's your name on the board and the wall. And they put that on YouTube and suddenly said, oh, Stephen Harkins had an operation. Yes. So our telescope comes out of the body, it switches off the feed.
Oh, I see. Okay.
So right. you guarantee anonymity and confidentiality. And there's another thing which is not artificial intelligence, but it shows the machine strength of it. When we put the instruments into the abdomen, the system knows exactly the point at where it goes through the skin. And so when it's working, it doesn't put any pressure against the skin in any direction or the abdominal wall. And the patients, as a consequence, experience much less pain post-operatively. They get up and move quicker. And it's remarkable difference. And we are about to do a prospective randomized trial between normal laparoscopy and robotic to confirm that advantage.
Isn't it interesting? I've never thought about pain management in robotics.
Yes, no, it's when you're doing normal laparoscopy, people put quite a lot of pressure against the abdominal wall. If they want to reach something, you just can't do it with the robot. It doesn't deviate by more than 1 millimeter or 2 in any direction. And we get less bruising, we see less inflammatory markers, and we have early data just showing less pain, quicker. Less pain means quicker ambulation, less clots, back to work quicker, etc., etc.
And I understand you're having a lot of success with thoracic work. Is that correct?
It is,
Okay,
yes.
so lungs,
Hmm?
lungs.
Yes, yes. So I think the really big area for us is lung cancer, and this week we started operating in the world famous Papworth Hospital in Cambridge, and it was just a joy to watch the team working, do a lobe resection, minimal blood loss, patient up quickly, in the recovery period, and and because it's a small cavity, a lung, and the
Yes.
robot gives you the opportunity the surgeon doesn't have to crouch or struggle with pose to get it. Surgeons sitting comfortably at a console working it, and they operate, and there were some very senior surgeons in theatre watching the first cases, and one of the men, who's a national clinical director for surgery, just said, "Wow, this is great. This is just great."
Fantastic. Oh, that's wonderful news. I'm pleased it's all going very well for you. All right. Well, I think I better let you get on with your day's work. Dr. Mark Slack, thank you very much for talking to us and the audience. I'm sure we've gained a great deal of insight into the struggles of the years, but you've had immense success, and I wish you all the very best in the future.
Stephen, thank you very much. It's been a pleasure talking to you as always, and love speaking about robotics.
Thank you. Thank you, Dr. Slack.